I'm Dr. Michael Latola.
And I'm Megan Strong.
Irrationally confident from my first gout gates last week, I try another new injection this week in our case of the week.
And find out why one man wants to change KFC's slogan to Teeth Chippin' Good.
And a Florida dentist gets a Brazilian dentist moves to Florida and does dentistry in a strange place. That and more on today's Chairside Live. Hey now, hello and welcome to episode 81 of Chairside Live. Megan, how are you doing today?
Ho, ho, ho! It's a very Merry Christmas here on the Chairside Live set, so I'm doing very well.
It's very festive. You've been saying ever since the middle of summer that summer means that Christmas is always here, even though they're 6 months apart.
No, summer means it's almost Christmas.
Almost. I think your progression was it means it's almost fall, which is almost Thanksgiving, which is almost Christmas.
Sure, something like that.
Or something like that. And now, look at this. We're resplendent in holiday decorations. It's here. It's snowing.
Oh, I love it.
Thanks to the magic of our producer, James. And it could turn to sleet or hail at any time, so be careful. Hail, large golf ball-sized particles bouncing off your head, so be careful. I don't want to see you knocked unconscious. Well, we got a great pre-holiday episode for you today. If you enjoyed last episode where I learned a new trick for the first time in 27 years, learning how to give a new injection, the gout gates, you're going to enjoy today's case of the week as well, because I'm going to give a second new injection for the first time in my career, the AMSA, anterior middle superior alveolar injection, which I'd heard about. What's that?
Say that twice.
I know. I've heard about it, but I'd never actually done it. And this is one of those ones where the gout gates, I was afraid of it, but it wasn't that big of a deal to do it. This one, I wasn't afraid of it, and then when I saw what was actually happening, and when you see what was actually happening in the patient's palate as I did it, I was more concerned because I'd never done this before. But Kathy, of course, was holding my hand, and everything went fine. So let's go ahead and take a look at that now. Well, Kathy, the great part about you being here is I get to do another new injection for the first time with your guidance, and you didn't even grab my hand during the gout gate, so that was pretty awesome. So this is the AMSA. I honestly hadn't heard of this injection back in dental school. I didn't hear of it until actually I started using the wand STA, and I heard people talking about it because for aesthetic dentistry, you could actually get from, say, second bite to second bite and the facial and palatal tissue all anesthetized. And instead of doing 10 infiltrations, you can go on both sides and do an AMSA and get the same type of anesthesia. And so 2 injections instead of 10, that sounds like a great idea to me. It just seemed counterintuitive to do it here on the palate for facial anesthesia. So I'm glad you're here to do this for the first time with me. So per your instructions, we're looking for where the curvature meets the flatter aspect of the palate right across, right in between, say, the 2 bicuspids, so right in here. And you mentioned pushing around.
Yeah, just gently walk until you find the little thickest pad of tissue in that area. And that'll allow us to completely cover the bevel adequately and actually have enough tissue to take up the anesthetic.
Yeah, it's right in there where
and we're kind of using a little more traditional approach, and we're going to go ahead and do the topical, and then we're going to follow it with some pressure on the site, which is a real common approach for the palate.
So is that when you say we're doing this instead of the more typical one? What is the more typical one? Just
I'd say this is the more typical combination here versus the no topical approach that you can do with the wand.
With just pressure instead?
Actually, the pre-puncture technique would have you hover the bevel right at the tissue, and you actually use the sterile cotton swab to compress the lumen the bevel right at the tissue, and get that first drop to enter right on the tissue. So rather than having a topical proceed, you actually are depositing the drug itself from the very initial penetration through the tissue.
Oh, got it. Okay.
Kind of takes using 2 hands together. Some people are comfortable with that, others aren't.
Yeah, and I guess it saves a little time. It cuts out this 60 seconds that we have here, but all right. That's our minute.
Okay, now that's our first minute. Now I'm going to have you go right back to the same place, and I want you to put pressure in this exact same place.
Okay.
And enough that we'd actually, see a small dimpling. And just hold that.
this for 60 seconds as well?
Correct. You know, and then similar to what you might do for greater palatine or other, you know, pressure anesthesia, just when you're ready, lift off the cotton and just go right for the middle of your dimple.
Okay, so we're not, like I remember being taught in school, well, for a palate injection, not this in particular, was the mirror handle and then inject next to the mirror handle. It's still in place.
And this one, you know, and if we're trading off just one right on top of the other, you know, not all clinicians are comfortable doing that. And then also to avoid actually, you know, taking our sterile needle tip right through and making contact with other objects. Okay. So I say just go right to the middle there.
And so again, we're coming, we kind of, as you said, park the bevel against the bone, so it's not coming across like this where we would hit the tip first and the bevel wouldn't be against the bone. We want to kind of make sure that that angle of the bevel is going to be right against the bone, as you mentioned.
And then from there, just, you know, same thing, just make your penetration, and it will be fairly shallow. And we're just going to advance till we have contact. And then for this one, we have our base unit set on the STA setting.
Okay.
And we may or may not hear the same you know, signals we get from the dynamic pressure sensing indicators.
Mm-hmm.
And we've got dense tissue. That same pressure can build up, but it's not necessarily a component of this injection.
Another cotton tip applicator I can borrow real quick. Just to
And that's why, like in our kit, we keep the sterile cotton swabs, a couple in a pack all ready to go.
Yeah, that's
so
really smart.
If we have any backflow, we can be collecting that, and they don't have to deal with the taste of it.
I can see that blanching that you said it was going to occur. It's going all the way up to the bicuspids.
Now, through the course of this injection, we are going to see that pattern, you know, extend oftentimes right to the midline and back, approximating the mesial lingual of the first molar. Everybody's going to be a little different. If your blanching pattern didn't go in both anterior and posterior direction, then you could choose another site and just, you know, step a little more distal if it was
now, this
not
seems
flowing
like,
distally.
This seems like an injection, this whole part delivering this, that would be really difficult with a manual syringe compared to just letting the computer do it nice and slow and steady. This seems hard to do with a manual one.
Well, and if we remember back to, you know, that feeling of what it feels like to give a nasopalatine, we're in that same dense tissue, so you have to maintain that pressure to keep the flow going throughout the injection, and that's really tiring. And one of the other things, I've always found it interesting, the same thing with the greater palatine. You can see the pinking right around your penetration site. For whatever reason, it's like the tissue always kind of fills in there last. Again, we've got a good blanching extending in both directions. And as we continue with that, we're going to have that fill in around at our penetration site as well. Now, depending on what drug we're using, we're going to be using anywhere from a half a cartridge to a full cartridge.
And you base it less on how much has gone from the cartridge versus the blanching pattern.
Correct.
The blanching pattern basically tells you when you're done here.
Yeah, and anytime you start seeing it actually dripping back out your penetration site, you know, the tissue's just not accommodating anymore. Solution. The other thing that we tend to notice with this one is as you retract the tissue back, we'll see this blanching, it is diffusing through into the buccal structures. And for some individuals, we'll see the same blanching on the buccal tissues at the end of this injection. And then, you know, that's a phenomenon where we're getting lingual gingiva, we're getting pulpal structures, and we're getting facial gingiva without getting any labial anesthesia. Which, if I've got my terminology right, allows you to see your zenith line.
Wow. Nice pull.
Ooh.
It's a state board's question. You're right. I see it up to the second molar now.
At this point, sometimes the patients will just have, you know, an experience of sort of, you know, just a pressure sensation. And when we're done, it's kind of like when you get peanut butter stuck to your palate, you know, that the thickening feeling
like
up there.
So do they start doing that?
They'll kind of,
like
they'll kind of start rubbing their tongue up there.
No offense, of course.
It just feels fat. And she looks pretty good, and we could probably, at this point, if I felt I had the whole extent, I would go ahead and stop my deposition at that point. We've got good blanching. And then actually go ahead and lift to the side after you withdraw, and let's see if we've got
Okay, you want to lift it? Which is on your, you mean over here on this side? I'm just going to make sure I don't.
And she's starting to get, she's starting to get, okay. And if you can turn to the
turn her
side,
this
see
way?
if we can get it. And you can see the blanching from the mesial or second
Oh,
molar
yeah.
through to her first bicuspid.
Look at that.
And that's as textbook as it gets, folks.
That's,
in fact, from this view, see how look right in the palate at the median suture?
right.
Can literally see the
Yeah, it
thin
stops
calf and
right
the
there.
blanch
You can
half.
see
It stops
exactly where
right
that
at the
stops,
median
and it goes
suture.
back to the second molar.
And then here we've got a diffusing
You should
clear
have bet
through
me
into there.
$20 that, and said, "Do you think it will blanch
Bet
on
to
the
pay.
facial, on the buckle if we do this?" And I would have said, "Absolutely not. You're
Absolutely not.
crazy." So it kind of travels, through that palatal tissue, then through the interproximal tissue, and then
Well,
onto
and actually
the
through the bone.
Through the bone.
We've got, it's moving, it's moving
Wow.
right through the bone, and, it's a short distance into that maxillary dental plexus. So we're getting, all of the
So based on the
innervation there.
signs, based on that palatal blanching and the blanching out to the facial, you're pretty confident that we've got good
I'm pretty confident we'd
second
be.
bite to second bite, pulpal anesthesia as well as
Well, in
the
this
facial.
one, we're only getting to the midline.
Right,
So if
right,
I'm
right,
doing,
right,
to the midline,
Yeah, we
but
have to do the same thing on the other side.
But I would feel confident in doing anything in particular from probably through her first molar bicuspids, and from a hygiene standpoint, we're going to pretty much get everything we need for
You get
for
the
doing.
first molar as well without the PSA?
In your particular case, we see blanching clear back to there, so I think it's likely that you would also have some anesthesia in the first molar, and if we had extensive procedures, we would go ahead and supplement that with the PSA on
So
that
what
side.
what I used to do is the PSA, MSA was like here, and then ASA here.
And if you had concern about crossover, sometimes then
then-
you're doing an additional infiltration
Right.
for any
But then
collateral.
only greater palatine they taught us, and then that palpating to see where the dimple was, and then just aim for that.
And with the greater palatine, it's not going to get any of the lingual
Yeah.
tissues in the anterior. And I'm sure if you rub your tongue up there, you can probably feel it.
Well, considering that's the first time I've done that injection, Kathy, that unlike the gough gates, there's not that feeling of I'm not sure where I am. You always know where you are, during this, and you just kind of watch the progression of the blanching. And even though, I think a lot of dentists are hesitate, including myself, to do a palatal injection if it's not necessary. When I compare that to going around and doing infiltrations on all the teeth, oh my gosh! I mean, that was, even though it's a palatal injection, so much more pleasant for the patient just to have 2 injections rather than have 10, and that whole bulk of anesthetic with it as well, versus barely under 2 carpules.
Well, in the time that's taken here is just for it to accommodate the solution, where in the other technique, you're correct. You're making an additional micro trauma, if you
Right.
will, with each one of those penetrations. Overall, probably take you the same amount of time.
Oh, I don't know. I think it would take longer for the other one. I think
would.
this is faster and probably better. I'm sold on this too. You're changing the way I do local anesthesia, and that's good. I was looking forward to that.
Yay.
Thank you for that, Dr. D.
You're welcome.
Okay, now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Tiffany Bueller-Schusler, and I hope I pronounced that correctly, Tiffany. She writes, Dear Dr. Detola, I watched your V Veneers video on the Glidewell website and had a question. I have a patient that is interested in them, but not the little edges at the gingival margin. Is it possible to do them, but prep a light chamfer so there's a definitive margin to seed against? Thank you.
I think you nailed that name, first of all. And Tiffany, or Dr. S, as I'm guessing, they call me Dr. D because
Right.
Detola is hard to pronounce. And so any name like that. But I think you nailed it.
Thanks.
That was fantastic. So, Tiffany, your question, can you prepare a light margin so you don't get those ledges, or as I like to call it, the speed bumps, because they're not a ledge in the sense that it's really sharp, but there's definitely an emergence profile speed bump there on a no-prep veneer. So the short answer to your question is yes, you can absolutely prep a light chamfer there, and they're going to be able to finish that veneer right against there, and then you won't have that bump. Now, the only caveat that you need to worry about for something like that is the draw, the path of insertion on something like that. So as long as you don't wrap the incisal edge with the veneer, you can go ahead and prep that facial margin, and they'll finish that veneer, and it'll just seat to place, like straight down from the facial right into place like that. However, if this patient wanted to extend the incisal edge on their teeth and end up with some longer teeth, for example, if you have 9mm central incisors and they wanted to go to 10mm, and you're going to wrap around the incisal edge and then finish on the lingual, now because of the way those veneers have to seat, there can't be any kind of pronounced undercut there from a light chamfer. So if you're not going to extend the length of the teeth and you either want to end it at the incisal edge, which is probably the best way to do it, then certainly prep that light chamfer and they'll seat right into place. But if you're going to add something to the incisal edge, if you're going to add a millimeter or 1.5 millimeters, then it gets more difficult because you have to do a little more preparation on the facial surfaces so you've got a nice path of insertion and it will actually draw. And so the V-Veneer video that you watched, we in fact did that with our pressed ceramic material at that time. Today, if I had to do most of those veneers again, I would do those in IPS Emax, and I'm going to suggest that you do the same. They are 3 times stronger than the old V-Veneers that we used to do, and we can now make Emax veneers as thin as those V-Veneers used to be, and I've in fact done some Emax veneers that were no prep, or in the case of what you want to do with that light chamfer on the facial margin right above the gingiva. So go ahead and do it, and if you're going to wrap the incisal edge, just make sure you've got some draw to it. You could always take a photograph of the prep and send it in if you wanted to, or just take an impression and send it in to us as well. You may or may not need anesthesia, of course, based on how sensitive the patient is, but it should work out great with IPS Emax, and again, those will be 3 times stronger than our regular veneer material. So thanks for writing in, Tiffany, and in fact, as you were selected by Megan as the letter of the week, I'm going to send you our reverse preparation kit. I'm not sure if you're planning on doing this as no prep or not, because on the V-Veneers video we did some as no prep and some as not, but if you are going to do a little reduction, there's a 0.6 tiny little depth cutter on here that you can use for some facial reduction, and if you don't use it for that case, you can use that 0.6 depth cutter for a Bruxer crown, for example, on a first or second molar, because that's the minimal thickness for that. So thanks for writing in, Tiffany. And this will be wrapped in a bow, hopefully.
Yes.
Do we have extra bows?
We do.
Okay, it'll be wrapped in a bow and sent to you as our Christmas present to you. So thank you for writing in.
Yes.
Any news for us today?
Yes. A Brazilian dentist in Florida is in legal trouble after authorities discovered he had been running an illegal dental practice. The man did not have a Florida dental license and practiced out of his laundry room in his home for 6 years. He treated 6,000 patients out of that room, complete with an exam chair and an X-ray machine. He cut a deal with prosecutors and will serve probation for 5 years, and community service and fines.
So it was a Brazilian dentist,
Yes,
in Florida,
without a license,
practicing in his laundry room.
his laundry room.
But now he's got 2 things in his laundry room that I don't have.
Okay.
And that would be an X-ray machine. I'll usually just check the pockets for change. I don't feel the need to X-ray it. And a dental chair, which I don't have. I have a bar stool if I ever just, wanted to sit there. So that's pretty amazing. But the truly amazing part is 6,000 patients. That's a lot.
It's unbelievable.
That's years and years worth of work. And again, being led through the house and going to the laundry room. And having
But I think the people that were going to him knew what they were getting into. They didn't just think this would, it would be my assumption, and we shouldn't assume, but I would think that the people would know, okay, normally dentists practice in an office. This is out of someone's home, and it's in their laundry room.
But consider this. How about getting your clothes washed while you got your dentistry done?
Wow.
See? That saves a trip to the dry cleaner on the way home.
It does.
So that's interesting, and again, this is one of those only in Florida stories. I feel. I don't know, I just feel like it's not going to happen in Wyoming and North Dakota, but
maybe.
Regardless. Anything else?
Yes. A man is suing the fast food chain KFC over a chipped tooth. He claims that he chipped his tooth when he bit into a chicken burger from their restaurant. The man is seeking $12,000 in damages for pain and suffering and medical bills. The man says he broke a left molar and will need ongoing dental treatment. KFC argues that the alleged pain is due to factors unrelated to the alleged incident. The parties will have settlement talks before a hearing at the beginning of next year.
I've wanted to sue KFC before.
For being absolutely delicious?
Yes, that's why, for being
Yes,
delicious. Those
100.
for the gravy and the mashed potatoes. And no, just made for just unrelated weight gain, to going there several times a week. and the one piece that I picked up that had a tail. Because chickens don't have tails, and so it makes you wonder what is underneath this batter. What is under this extra crispy batter? I've had patients break teeth at restaurants before.
Yeah.
And oftentimes they'll come in and they'll blame the restaurant and they'll want me to contact. They've asked me to contact the restaurant. And they'll say, well, no, you're going to have to contact it. And then usually the restaurant contacts an attorney, and the attorney calls you, and they want to see x-rays. And it's usually pretty clear. If somebody breaks a tooth, I can think of somebody with a chicken salad, and the attorney requested an x-ray, and we had an x-ray from their cleaning almost 6 months ago, and you could see the decay on that tooth. And so it was clear that it probably wasn't the chicken salad.
Right.
Another time we had somebody eating olives that were out of a can, and it had a part of a pit in there. And they said they broke a tooth because of that. The x-rays didn't show anything, and so the olive company actually sent us something to pay for the cost of the crown that was done. But that was it. $12,000 for a chipped tooth sounds like a little bit opportunistic. I mean,
just a tad.
I know. I don't know how much pain and suffering, because they didn't mention root canals or anything else, or a vertical fracture where it needed to be extracted. So I don't know. I worry about that. We have our own cafeteria here. I've never seen anybody who gets into trouble, but biting into something and having a crack. So I guess we've been lucky that way.
Yeah, we have.
You've never broken a tooth at a fast food restaurant?
Not at a fast food restaurant, but I cracked a tooth on an almond or a walnut a long time ago, but there was no adult tooth behind it. It was a baby tooth that hung on until I was 18, and then it cracked, and then it was gone, and now I have an implant in there.
Oh, you do?
Yeah.
I didn't know that.
Yeah.
Oh, you got an implant in there. Oh, we should take a close look at your mouth one day. Take some x-rays and put it up on the screen. How was that, the whole procedure of getting the implant?
I'm going to be honest here. It was absolutely traumatic because I don't think that it was almost rejected, I believe, and so then they had to go back and redo it. Are you kidding? It was not fun.
Really?
Yeah.
I'm glad I wasn't there. I'm glad I'm not the one who did it.
I was going to say, where were you when I needed you?
For my first implant, I was cowering in the corner, afraid to put the implant in your mouth because. So they literally had to take it out once and then put a second one in?
Yes.
Oh, wow.
Yeah.
Wow.
That was fun.
I don't know if it was rejected or something with the technique. How many years ago was it?
I was 18, so 8.
8 years ago. Well, I'd like to think today with guided surgery and that we know a little bit more than we do 8 years ago, and we'll probably know more 8 years from now. But now it's fine. Now it's doing okay?
Yep.
Interesting. Well, good for you. I'm glad you had it done and not 18 years ago. Things were brutal back then.
Oof.
It may not have gone well. All right. Thanks so much for that. That about wraps it up for this week's edition of Chairside Live. On behalf of myself, Megan, Santa Claus, the reindeers, Margaret, and Tara, and CSL for you on the Yeah, you got to really scruff the cat and hold her down and then grab her back legs. And she doesn't like having her nails done.
Sounds like my grandpa. Is it possible to do them, but prep a light chamfer? I stopped in paused because it made me nervous. Again.
Those are scary. Do you want to...
You're rude.
Well, we've got a great episode for you today. An interesting case of the week. If you enjoyed last year watching me...
And find out why one man wants to change KFC's slogan to cheat mommy.
To cheat on mommy.
Ho, ho, ho.